Assalamu alaikum wa rahmatullahi wa barakatuh. Welcome to the channel of Easy Medical Notes, which is a summary of standard medical textbooks like Harrison, Davidson, Oxford, McMaster, Pocket Medicine. So let us learn today about the next cardinal symptom of both cardiac and respiratory system, that is chest pain. So let us start. Chest pain is a very common symptom in emergency rooms like vice breathlessness. So first point is chest pain may originate from all structures of the chest except the pulmonary parenchyma. Chest pain can arise from any structures of the chest, but it except the pulmonary parenchyma. Chest pain is clearly a subjective phenomenon and may be described by patients in a variety of different ways, like pain, discomfort, or pressure in the chest. Etiology and clinical manifestations. There are some clinical features that must be elicited from the history which will help to narrow down the diagnosis. First cause, myocardial ischemia, which can manifest as pain or most of the time pain, and in some patient as breathlessness. Pain at the center of chest may radiate to the neck, jaw, and upper or even lower arms. Occasionally, it may be experienced only at the sites of radiation. This is very important, but occasionally it may be experienced only at the sites of radiation or in the back. So sometimes patients only have pain at the site of radiation, not at the center of the chest. This is also very important point. Typically, that pain is described as dull, constricting, choking, or heavy squeezing, crushing, burning, aching, any type of pain they can describe. Patients often emphasize that it is a discomfort rather than a pain. Breathlessness due to pulmonary congestion arising from the transient ischemic left ventricular dysfunction is often a prominent feature of myocardial ischemia. So this is also known as angina equivalent. Instead of having chest pain, they will have breathlessness upon exertion. So breathlessness, myocardial ischemic pain can present as these. So it is a spectrum. It is a spectrum actually. So progressing from angina to MI, from angina to MI. It is a spectrum actually. What is angina? Angina is nothing but the similar pain which is described in myocardial ischemia occurs during, not after exertion, during exertion, and is promptly relieved in less than 5 minutes by rest or after taking nitrates. So angina means three features. It is produced by exertion. The pain is produced by exertion, during exertion. Number two, relieved by rest relief, or relieved by nitrates relief. So any pain having these three features, chest pain with produced during exertion and relieved by rest or with nitrates, then it is called as typical anginal chest pain. Typical anginal chest pain. If two are there, one is not there, then it is known as, one is typical, then it is known as atypical anginal chest pain. Atypical anginal chest pain. Only one is there, then it is known as non-anginal chest pain. Non-anginal. Okay, remember this one. So angina occurs during exertion, relieved by rest, and after taking nitrates. Crescendo or unstable angina, pain may be precipitated by minimal exertion or at rest or rapidly increasing intensity. Decubitus angina. So when the patient lies down, there is increase in venous return, which causes increased P load that is sufficient to provoke pain in vulnerable patients. So when the patient lies down, he will have the chest pain. That is known as decubitus angina. So the last one is myocardial infarction. The pain is similar to angina but lasts more than 20 to 30 minutes and not resolving on rest or taking nitrates, and often it is associated with autonomic symptoms. That is the chest pain of myocardial. Autonomic symptoms like sweating and tachycardia, breathlessness, all these are autonomic symptoms. So that's about the pain of myocardial ischemia. Next, coming to the second important cause of chest pain, that is aortic dissection. Severe tearing type of chest pain, mainly central with radiation to the back. One important point here to remember: pain of aortic dissection, massive pulmonary embolism, pneumothorax are very sudden in onset. That is one important point to remember. Another important point: pain of MI, massive pulmonary embolism, and aortic dissection, meaning cardiovascular causes of chest pain, often accompanied by autonomic disturbance like sweating, nausea, vomiting. And some patients describe a feeling of impending death during the pain, that is referred to as anger anima. They will fear, I may die now. That is seen in cardiovascular causes of chest pain like myocardial infarction, massive pulmonary embolism, and aortic dissection. And sudden onset of chest pain is seen in aortic dissection, massive pulmonary embolism, and spontaneous pneumothorax. So this is the point to remember. Now moving forwards. Anger enemy. Remember anger enemy. Pain of myocarditis and pericarditis. Pain is characteristically felt retrosternally to the left of the sternum or in the left or right shoulder, also described as sharp and may catch during the inspiration. This is typical of myocarditis or pericarditis, similar to pleuritic pain. So pain is sharp and it may catch during inspiration, coughing or lying flat, and decreases in upright and bending forwards. Patient may describe a prodromal viral illness, so viral pericarditis or myocarditis. That's about the pain of myocarditis and pericarditis. Now coming to the pleuritic, is similar to the this one pericardial pain. This will have pericardial rub, this will have pleural rub. Remember this one. That is a differentiating feature actually. So pleuritic pain or pleurisy, it is a sharp or catching chest pain. Catching means when the patient inhales, suddenly some stop or some catchy thing will happen. That is catchy chest pain. So it is a sharp or catching chest pain aggravated by deep breathing or coughing, and it is indicative of respiratory pathology, particularly infection or infarction, and also in pneumothorax. In pneumothorax, when there is accumulation of air, sudden accumulation of air in the pleural cavity, there also you can see pleuritic chest pain on the lateral side of the chest. Remember, this pleuritic chest pain is on the lateral side of the chest, and myocarditis and pericarditis is mainly on the central part of the chest, but sometimes it can also present at the lateral side of the chest. Moving forwards. Malignant tumor. Any malignant tumor invading the chest wall or ribs can cause gnawing, continuous local pain. So these are the main important causes of life-threatening causes of chest pain which we should rule out. One is myocardial ischemia, aortic dissection, pulmonary embolism, massive pneumothorax, and pneumothorax. Okay. Next, coming to pericarditis, myocarditis, tumor, and next there was cardiovascular and pulmonary disorders. Now this is GI disorders. Coming to the GI disorders. So GERD, gastroesophageal reflux disease or peptic ulceration, may present with chest pain that is hard to distinguish from myocardial ischemia. Yeah, it may even be precipitated by exercise and be relieved by nitrates. The pain of GERD often radiates through the interscapular region. However, it is usually possible to elicit a history relating chest pain to supine posture or eating, drinking, esophageal reflux or dysphagia. So this is the thing which will differentiate it from MI. Okay. Next is esophageal perforation. Severe chest pain arising after retching or vomiting, severe vomiting, or following esophageal instrumentation should raise the suspicion of esophageal perforation. Next is acute pancreatitis. Severe epigastric pain associated with vomiting, and there will be history of chronic alcohol intake. Patient will bend forward due to the pancreatic pain. Next is gallbladder pain, hepatic pain, and subdiaphragmatic abscess. These can all radiate to the epigastric pain, epigastric region. So these are the causes of GI disorders, GI causes of chest pain. Now coming to the musculoskeletal causes of chest pain. Musculoskeletal cause: pain that occurs after, not during, after rather than during exertion is usually musculoskeletal or psychological in origin. The pain may vary with posture or movement of the upper body or be associated with a specific movement like bending, stretching, turning. If this is the feature of pain, then it is most likely musculoskeletal pain. But remember, pericardial or pleuritic pain can also be produced by movements, but there will be no catch in respiration in here in musculoskeletal pain, and there will be no pleural rub or pericardial rub present here. Okay. Here one important point: the absence of pleural rub with effusion along with tenderness on palpation suggests muscular pain. Absence of pleural rub and with tenderness suggests musculoskeletal pain. So you need to differentiate between pericardial pain, pleuritic pain, and musculoskeletal pain. Pericardial pain, pleuritic pain, they will have pleuritic nature, catch during inspiration, and they will also be increase or decrease on the posture, but there will be associated pleural rub or pericardial rub, and there can be tenderness also there also. But in musculoskeletal pain, the pain does not have pleural rub or pericardial rub, and the absence of rubs with tenderness suggests musculoskeletal pain. Coming to the psychogenic cause of pain, anxiety induced chest pain may be associated with breathlessness without hypoxemia. So here there will be no drop in saturation, and it will be associated with throat tightness and perioral tingling and other evidence of emotional distress. So these are the causes. The first cause is uh, cardiovascular and pulmonary cause. Pulmonary mainly pneumothorax or infection or infarction. Second cause is uh, GI cause. Third cause is musculoskeletal cause, and the fourth cause is psychogenic cause. So this is the causes of chest pain. These are the causes of chest pain. Okay. Now coming to, this is a good diagram to remember. See, retrosternal pain. Remember this one. and also this retrosternal pain. What may be the causes? Myocardial ischemic pain, pericardial pain, esophageal pain. Remember the central structures of the chest. So those the causes of the central pain are the central structures of the chest. Myocardial ischemic pain, pericardial pain, esophageal pain. There will be aorta, aortic dissection, mediastinum will be there, mediastinum lesion, and mass pulmonary embolization. These are the causes of central retrosternal chest pain. Then causes of epigastric chest pain. Causes of epigastric chest pain: myocardial ischemic pain, pericardial pain, esophageal pain, duodenal gastric pain, pancreatic pain, gallbladder pain, distension of the liver, diaphragmatic pleurisy, pneumonia. So here you will have mostly cardio or GI causes. Here mostly retrosternal central chest causes, central chest structures causes. The shoulder pain, myocardial ischemic pain, pericarditis, subdiaphragmatic abscess, diaphragmatic pleurisy, cervical spine disease, very important, acute musculoskeletal pain, and thoracic outlet syndrome, ischemia, pericarditis, subdiaphragmatic abscess, diaphragmatic pleurisy, cervical spine disease, acute musculoskeletal pain, thoracic outlet. Arms, myocardial ischemia, cervical pain, or thoracic outlet syndrome. Okay, next, interscapular, myocardial ischemic pain, musculoskeletal pain, gallbladder pain, pancreatic pain can all relate to interscapular region. So you can remember this also. What are the cause of right lower anterior chest and right lower left lower anterior chest? Mostly there will be intercostal neuralgia, pulmonary embolization can present sometimes and left, but mostly present in the retrosternal aspect. So one point to remember importantly here is serious intrathoracic or subdiaphragmatic diseases, means serious intrathoracic and abdominal causes, are usually associated with pain that begin in the central or left anterior chest, left shoulder or upper arm, the interscapular region or the epigastrium. This image depicts that thing. So these areas which are highlighted here, this area, this one interscapular, this epigastric, and this left anterior chest and shoulder and left upper arm. So these are all signify some serious intrathoracic or abdominal cause of chest pain. Whenever you see a patient with describing chest pain at this side, think of some serious intrathoracic or abdominal cause of chest pain. Moving forward, so this is the summary of our chest pain topic. So first you need to differentiate between cardiac and non-cardiac chest pain. So cardiac will be central and diffuse. It can radiate to jaw, neck, shoulder or arm. It is usually tight, squeezing, choking type. So this is one thing, first typical feature of pain. Then it is precipitated by exertion and or emotion. So this is the second thing. And it responds to rest or quick response to nitrates. This is the third thing. So these three imply typical, these are called typical anginal pain. If any two of there, then it is called atypical. If any one is there, then it is called non-anginal pain. And associated features with cardiogenic pain is breathlessness. Okay, the whole summary. So you can divide the acute chest pain causes as cardiopulmonary and non-cardiopulmonary. Cardiac causes include, first is myocardial ischemia. So it can be stable angina precipitated by exertion, cold or stress 2 to 10 minutes, and it can be stable and unstable angina, increasing pattern or the angina at rest, or it can be MI, usually more than 30 minutes. Quality, pressure, tightness, squeezing, heaviness, burning, anything. Location, often retrosternal, often radiation to neck, jaw, shoulders or arms, sometimes epigastric and sometimes only at the site of radiation. Associated features of ischemia, there can be S for gallop, triple murmur, or mitral regurgitation murmur during pain. S3 or rales if severe ischemia or complication of myocardial infarction. So that's about ischemia. Second is, that was muscle. Okay, this is pericarditis. So onset is from variable, hours to days, and maybe episodic also. Pericarditis, it is pleuritic and sharp type of pain, catchy, and location is retrosternal toward cardiac apex, may radiate to the left shoulder. Okay, associated features will be, may be relieved by sitting up and leaning forward. There will be associated pericardial rub. That's about the cardiac causes of chest pain. The cardiovascular cause of chest pain, aorta is there and pulmonary artery is there. So aorta, acute aortic syndrome like aortic dissection, sudden onset of unrelenting pain, tearing or ripping, knife-like pain. Location, anterior chest, often radiating to back between shoulder blades. Associated with hypertension or connective tissue disorder. Murmur of aortic regurgitation can be there. Loss of peripheral pulses, and two important things are signs are I need to say. There will be asymmetrical BP if you measure the BP in both arms. And always remember, when there is a patient of chest pain, you should measure the BP in all the four limbs, upper limbs and lower limbs also. So there will be loss of peripheral pulses, and if you measure the BP in right arm and left arm, there will be difference of 20 mm Hg. Normally it is less than 10 20 mm Hg. It will be more than 10 mm Hg in aortic dissection. And one more point is, there will be neurological features associated with aortic dissection. Some weakness, hemiparesis, paraparesis like features will be there in aortic dissection. So one is aorta. Second is pulmonary artery. So pulmonary embolism, sudden in onset, pleuritic type of pain. Pulmonary embolism also produces pleuritic type of pain, may manifest as heaviness with massive pulmonary embolism. If the embolism is not massive, then it is pleuritic and lateral side of chest. If it is massive, mostly it is central retrosternal pain, and it feels as heavy pain. Often lateral side if it is not massive, on the side of embolism. Associated with dyspnea, tachypnea, tachycardia, and hypotension. Remember that chest X-ray sign, silent chest, raised JVP, but no chest X-ray changes, and there will be hypotension. All those and breathlessness will be there. Then pulmonary hypertension, often exertional chest pain will be there because of right ventricular hypertrophy. Quality, pressure type, substernal, associated dyspnea and raised jugular venous pressure. Because of raised right heart circulation pressure, there will be raised jugular venous pressure, exertional chest pain of pulmonary hypertension. So that was the causes of vascular causes of chest pain. Next, coming to the pulmonary causes of chest pain. Pulmonary causes, so either it can be pneumonia or pleuritis. Onset is variable. Chest pain is pleuritic, lateral side, unilateral, often localized. Associated dyspnea will be there, cough will be there, fever will be there, creps will be there, and occasionally pleural rub will be there. and this is very life-threatening important cause: spontaneous pneumothorax, air between the pleura and the chest wall, sudden onset pleuritic pain lateral to side of pneumothorax associated with dyspnea and decreased breath on side of pneumothorax, unilateral silent hyper resonant chest. Okay, so that was the cardiopulmonary causes of chest pain. Cardiac can be divided into muscle ischemia or pericardium, vascular, aorta, and pulmonary artery. And a pulmonary, pleuritic due to pneumonia, secondary pneumonic effusion, and second one is air, pneumothorax. Now coming to non-cardiopulmonary cause of chest pain. Number one is gastrointestinal. In that, esophageal reflux because of lower esophageal sphincter tone. There will be reflux of acid. So onset is from 10 to 16 minutes. Burning type of pain, substernal or epigastric, worsened by postprandial recumbency or relieved by antacids. So this is the feature of, so in relation to meal is the feature of reflux pain. Then esophageal spasm is the next cause. Onset is 2 to 30 minutes. Presence as this is very very important when there is esophageal. So in some patients who are anxiety like personality, the lower esophageal is very sensitive to foods and acid. So it is something called as what do you call it, lower esophageal hypertonic lower hyper contractile lower esophageal, hyper contractile lower esophagus it is called. In some patients it is there. So that spasm of esophagus due to because of high sensitivity of the esophagus, so that will produce pain similar to like myocardial infarction. So you will have pressure, tightness, burning, retrosternal. Closely it mimics angina. Okay, then peptic ulcer, prolonged pain, 60 to 90 minutes after meals, burning type, epigastric and substernal, relation with food and acids. Remember, all these gastrointestinal causes of pain have association with meal. Gallbladder disease, prolonged pain, colicky it will be, and it will be associated vomiting, right hypochondriac mostly. It can be epigastric, right upper quadrant, sometimes to back. It follows the meal. So every cause of GI cause will be related to chest pain. GI causes are either reflux, spasm, peptic ulcer, or gallbladder. So next, moving on to the neuromuscular causes of chest pain. So it can be costochondritis. So the junction of sternum and ribs, there are joints, no, costochondrial junction. So that is inflamed due to some viral infection or something. So that causes costochondritis. So pain time of onset is variable. It is aching type of pain, and it is sternal, sometimes swollen, tender, warm over joint, may be reproduced by localized pressure on examination. Remember one point about pain: visceral pain is non-localized, and somatic pain is usually localized pain. This is a basic thing which we learn in pain. And neuropathic pain is something which is like electric shock like sensation, tingling, burning, and hyperallodynia. If you touch also, it will produce pain like symptom. So basically three types of pain are there: somatic, visceral, and neuropathic. In somatic pain, it is very well localized, whereas visceral pain is not very well localized. And this neuropathic pain is very different from that which I said. So costochondritis. Second is cervical disc disease. This is also very common. Onset may be sudden or variable. Aching or may include numbness of the that limb, upper limb. Present where it is present, quality is aching, arms and shoulders, and it is mostly exacerbated by the movements of the neck. Movements of the neck will exacerbate this one. And trauma or strain, usually constant pain, aching, localized area of strain, reproduced by movement or palpation. trauma strain, somebody is working heavy work, he has somebody is mechanic, or somebody does the job of lifting heavy weights, so they will have trauma or strain, and they will come with pain. I am having pain, I do this job, that job. Then you should suspect traumatic or strain type of pain in those patients. So the third type of pain, one is costochondritis, second is cervical disc disease, third is trauma or strain, fourth is neuropathic, which is herpes zoster, prolonged pain, sharp and burning, dermatobal distribution, and there can be vesicular rash in the area of discomfort. That was neuromuscular causes of pain. So in GI causes, it is reflex, spasm, peptic ulcer, gallbladder. In neuromuscular, costochondritis, cervical disease, trauma, strain. And psychological causes, psychiatric conditions, onset is variable and quality is also variable, associated with tightness, dyspnea, panic attacks, and the site of pain is also variable. Situational factors are associated which may precipitate symptoms. There will be history of panic attacks and depression. So by this we conclude the causes, clinical features, and the definition of chest pain. In the next class, we will discuss about how to approach a patient in the emergency department or in the OPD of chest pain, and how to investigate him and how to treat him. Okay, thank you.